Hello and welcome to Professor Trulove's Concepts for Nurses series. And I am Professor Terry Trulove. And in this episode, we are going to look at some of the ways we can apply electricity to help treat and care for our patients suffering from cardiac problems. That is, better medicine with Edison, where we'll look at temporary and permanent artificial pacemakers, defibrillation, and cardioversion. Sources for this episode include Iggy's Medical Surgical Nursing and Soul's Introduction to Critical Care Nursing. An artificial pacemaker is a device which takes over for the intrinsic pacemakers of the heart when those pacemakers have failed because of heart disease or other conditions. Artificial pacemakers can be permanent, that is, implanted in the body, or temporary, where the impulses are transmitted through the skin to the patient's heart. A unipolar lead is a single conductor lead with an electrode located at the tip. A bipolar lead has two separate and isolated conductors within a single lead. The distal electrode is located at the tip of the lead, and the other one is usually about 2 centimeters more proximal. The advantage of the unipolar lead is that it stimulates the heart more efficiently than the bipolar. However, the bipolar tends to sense the intrinsic rhythm of the heart much better than the unipolar lead. Some of the newer defibrillators are trying to combine the advantages of the unipolar and bipolar lead layout. Conditions requiring consideration of the use of a pacemaker, temporary or permanent, include symptomatic bradycardias from such sources as sinus bradycardia, sick sinus syndrome, sinus arrest, sinoatrial exit block, atrial fibrillation with slow ventricular response, and atrioventricular blocks. Recall that most of the frontline antidysrhythmic medications designed to stimulate, that is, increase the heart rate, do that by affecting the SA node. An example is atropine sulfate. However, in many of these listed conditions, there is not good communication between the atria and the ventricles, and therefore, these medications won't work. Pacemaking is therefore indicated. So, to pace a heart is to send an impulse to the patient's heart to promote depolarization. To capture means that the pacemaker is able to cause the depolarization of the patient's heart. If the impulse, that is, the amount of electrical energy sent to the heart, is not sufficient, the myocardium will not depolarize. Therefore, enough energy needs to be sent from the machine to the heart in order to capture, that is, cause the myocardium to depolarize. To sense an impulse means that the pacemaker sees or detects the patient's own inherent QRS complex, and in this way does not compete or interfere with the intrinsic rate of the heart. This happens because the pacemaker can be inhibited, and that means that the pacemaker does not send an impulse because it has sensed that the patient's heart is depolarizing in a normal way. Pacemakers can be temporary or permanent. Temporary pacing can be invasive or non-invasive, and permanent pacemakers are pacemakers that are tucked into the body and that have a long-lasting battery so that they can be left into the patient for prolonged periods of time. They can be programmed remotely through various methods, including electronics and magnetism. This illustration shows the pacemaker pulse generator attached to the heart via the leads coming from that pacemaker. And in this case, we have a lead in the right atrium and the lead in the right ventricle. Allow us to do what's called AV pacing, or atrioventricular pacing. Components of the artificial pacemaker include a generator, which creates the energy needed, a governor or brain, which is a small circuit board which gives the instructions to how the pacemaker is either going to react to the heart or give the heart impulses in order to beat. A battery to store the energy from the generator, and leads to move the energy from the pacemaker generator to the myocardium. The energy impulse from the generator occurs very quickly and will reveal itself in an ECG strip in a characteristic up and down motion that is known as a pacemaker spike, and one of those are illustrated here. On the far left-hand side, we can see the atrial pacemaker spike, followed by a P wave, and then a ventricular pacemaker spike, which is followed by a QRS complex. Notice that the QRS complex in this case is wider than normal because this impulse will not travel down the pathways, but instead will have to travel around the ventricle itself. When we look at this type of pacing from another angle, we see, again, the characteristic pacemaker spikes, followed by a P wave, followed by the ventricular pacemaker spike, followed by the abnormally wide QRS. Both the atria and the ventricles are being captured by this pacemaker because depolarization of the atria and ventricles are being proved by the presence of the P wave and the QRS complex. This illustration shows the placement of pads so that transcutaneous or non-invasive pacemaking can occur. You see that we have an anterior pacing electrode and a posterior pacing electrode. This device sends an impulse through the skin to the heart. The pads are electrodes, and the closer to the heart they are, the better the performance of the transcutaneous pacemaker. This type of pacemaking is painful and should only be used as a temporary gap until transvenous pacemaking can be established. You should also know that although these are very versatile pads, they cannot be used as both a pacemaker impulse generator and a sensor. These devices, therefore, will require you to have a separate set of electrodes, that is, ECG lathes available to talk to the temporary exterior pacemaking generator. In fact, this illustration shows one of those devices. Notice on top that the pacemeter registers every pacing stimulus delivered to the heart, and the sensing meter registers every time an intrinsic depolarization is recognized. Going down, we see that the first dial is the rate control, which sets the number of pulses to be given with each minute. The output controls determines the amount of electricity sent to the heart, and it is measured in milliamperes. The sensitivity of the pacemaker can be set with the lower dial. This adjusts the pacemaker's sensitivity to the patient's electrical activity, that is, their heart rate. And of course, power buttons are found at the bottom of the device. These devices can either be set to pace only the atria, only the ventricles, or the atria and the ventricles. They can also be sensitive to the intrinsic heart rate and increased workloads. For instance, there may be a time where maybe the patient's having a little bit more activity and the rate will have to be adjusted for that. It is important, therefore, that we know that there are different types of modes for pacemaker and that there are letters and a pattern to describe what those pacemaker modes are. The modes are described by 4 letters. The first letter describes what is being paced, that is, the atria, the ventricles, or both. The second letter describes what is sensed. The third letter describes what the response of the pacemaker will be, while the fourth letter describes any programmable functions. And letters used to describe include A for atrium, V for ventricle, D for dual or both, O for none, I for inhibited, and R for rate responsive. Let's look at some examples of pacemaker modes. In an AAO mode, this would describe a pacemaker that senses and paces the atria. It does say ventricles here, but that's an error, but does not have programmable properties such as a rate response. The VVI mode would describe a pacemaker that senses and paces the ventricles and inhibits an impulse when it senses a patient's QRS. A DDDR mode would describe a pacemaker that triggers and inhibits both the atria and the ventricles, and that is rate responsive. That is, sensitive to the needs of the patient's metabolism. What you're hoping for when using a pacemaker is to avoid cardiac arrest. Let's briefly talk about cardiac arrest because although modalities such as closed chest compression, vasoactive medications, antidysrhythmic medications are those that come to mind when thinking about the management of cardiac arrest, we know that there's also going to be the use of electricity. So, to review, in CPR, maintain the patient's airway, ventilate with mouth-to-mask device or a bag, start chest compressions, and we need to consider that there are three branches now for advanced cardiac life support. They include the treatment for bradyarrhythmias, the treatment for tachyarrhythmias, and the treatment for pulsus arrhythmias. In some instances, for instance, with tachyarrhythmias, it is important that we take control of the out-of-control rhythms that are occurring in the heart. In that case, we may want to defibrillate or cardiovert. Well, what is cardioversion? Cardioversion is a synchronized countershock. It is used in emergencies for unstable ventricular or supraventricular tachydysrhythmias, and it can be used electively for stable tachydysrhythmias that are resistant to medical therapies. So cardioversion can also be used for such rhythms as atrial fibrillation with a rapid ventricular response and atrial flutter with a rapid ventricular response. Synchronized cardioversion is designed to depolarize the ventricles all at once. What we hope to do is to take control of the rhythm of the heart. And in this example of cardioversion, we see that on the left side, there is a heart rhythm that is in atrial fibrillation. Exactly on the next R wave, a shock is delivered, a cardioversion shock, and a synchronized cardioversion shock because it occurs directly on the R wave. On the right side is the intended outcome, normal sinus rhythm of a cardiac conduction system that has been brought back under control. Cardioversion is considered when the patient has an intrinsic QRS and usually will have a pulse. However, in cases where there is absolute chaos in the ventricles, that is, the ventricles are in fibrillation, we should apply an asynchronous countershock that depolarizes the critical mass of the myocardium simultaneously in an attempt to stop a re-entry circuit and allow the sinus node to regain control of the heart. That intervention is known as a defibrillation or a defibrillatory shock. By essentially forcing the myocardium to all depolarize at once by an overwhelming application of electricity, the hope is that that allows repolarization to take effect under a more organized manner and reset the timing to essentially a normal sinus rhythm. Here we have an example, and up until the arrow, you see the chaos associated with ventricular fibrillation, in this case, coarse ventricular fibrillation. We see the spike indicating a massive jolt of energy delivered as a defibrillatory shock, followed by a normal organized QRS complex to the right of the shock. You should know that the patient will be getting CPR before the defibrillatory shock. The shock should then be applied and CPR should immediately commence to assist the heart with circulation and to prevent the heart from suffering from an ischemic injury. And not so shockingly, we have reached the end of this episode and the last of the ECG episodes. But we are not done with the cardiac series yet. So I do hope you learned a little bit. I hope you're planning on coming back to listen some more. And if you are, we'll see you then. Bye now.